Okay. This is Janine Blanchard, and we met, I'm going to say a few years ago. I don't remember exactly how many years ago. And the way I met Janine is that she treated me. And she has wonderful hands. She was working together with Jeffrey Birch, one of my favorite colleagues and very good friends as well. And I'm excited to hear and see and experience what you have to teach us about the vagus nerve. And of course it ties in really wonderfully with Michelle's presentation, and Janine is going to teach us also some wonderful release techniques for working directly with the vagus nerve as well. Thank you, Janine.
Thank you, Carol. So I'll start from the beginning. I am so excited that this presentation is following the one you've just seen from Michelle. Her presentation was more on the social interactions. We're going to have some table time, some exchange time to work with the vagus nerve directly. And she mentioned quite a few things that I am going to repeat some of them. But I was actually excited to hear her mention a few things already, because that means we have more time on the tables, and I think that'll be really good. And Michelle and I were in contact before, a few weeks ago actually, talking about our presentations, and both agreed how valuable and complementary both of them will be. So let's look at what to expect. My goal with this presentation is to tell you what the vagus nerve is, why it matters, and how to work on it, how to directly have access to it and work with it. So why the vagus nerve matters? Clicker doesn't work. What it is, we'll look at some pretty detailed anatomy of it and why it is important to work with it. And then the hands-on part is the how to work with it. So I want to continue along the lines that Michelle has, we have some time for Q&As as well, hopefully. I want to continue along the lines that Michelle was talking about, so vagal tone studies. And again, looking at facial expressions here, I think that really represents well what Michelle was just talking about. And I want to mention 3 of Porges' studies, so the guy, the inventor of the polyvagal theory. And I want to define vagal tone just so you know what we're talking about. It is measured in the ratio of heart rate to breathing. Put it really simply. There are a lot of details to it, but that is the definition of vagal tone. And Porges has found that in general, infants with higher vagal tones, and I know Michelle mentioned this already, but again, have greater soothability, have better visual attention. Oops, sorry. This guy right here. Visual attention, more approach behaviors, greater emotional expressivity. So, this guy falls under that as well. He's really able to express himself. Fewer emotional problems. And then on the other side, infants with low vagal tone tend to have problems with regulation of sleep, emotional distress, digestion is a big one, attention disorders. And another study that I find really interesting that Porges did was around circumcision. So obviously, circumcision is a stressful event for any baby. It doesn't matter where its baseline was. But the babies with a high vagal tone, a high vagal baseline, were much more easily able to settle back into a good vagal tone. The vagal tone dropped for all the infants during and shortly after circumcision. But that is what Michelle was talking about. She used the word resiliency. So be able to cycle back into a more settled state. So the babies with perinatal difficulties, premature babies, they all had a harder time settling back into the high vagal tone. And so if we look at this picture, this is an image from a cranial nerve book. It's a great book, I love it. The blue lines right here, this is what the vagus nerve is, right? You see it, we'll go into detail more later. You see it connecting to the lungs, innervating the heart, the whole digestive tract. This already shows to me how much implications the vagus nerve has in the body. And I want to bring in a quote from the founder of osteopathy, where my background is, Andrew Taylor Still. And he said, all tissues need adequate fluid, nutritional, and neurological exchange. So if that is not given for a nerve, if it doesn't have adequate fluid, nutritional, and neurological exchange, a nerve is innervated as well, it can't function properly. And that's when this osteopathic principle comes in. Structure and function are interrelated. This is what this presentation is about to me. A vagus nerve cannot function properly if it's restricted, if there is some sort of lack of movement. You might want to call it inertia. There are a lot of different terms we use for it. But we need to look at function. This is what we want it to do well. And if it's restricted in any sort of way, it can't do that properly. And that's where the hands-on techniques will come in today. And to me, what inspired me to do this presentation is what I call the cumulative effect of vagal trauma. And this is actually my adult clients, my motor vehicle accident clients, where I noticed some were able to recover so well from things like whiplash, all the other implications of a motor vehicle accident, but mostly it came to me to this neck area. I noticed some people were able to recover much quicker than others. And I started asking questions. And I asked about childhood, about safety, what Michelle mentioned, about any sort of digestive distress, about, let's see what else. I like to ask about colics, about even their digestion right now. And I noticed there was a pattern emerging. Granted, this is not a scientific study, but it was my clients, where I noticed all these clients that have a harder time recovering. And granted, I worked on the vagus nerve as well with all these clients because it came up in my evaluation to work with it. I noticed they are not able to recover as quickly because of the cumulative effect. So they've had vagal trauma most likely all their life. Maybe it happened during birth or any kind of bigger fall or concussion. That all happens. That's life. They weren't able to recover as quickly. And so this comes back to me to, we need to be able to work with this as early as we can in infancy, in childhood, if it comes to us. And another aspect is we always talk about the gut-brain connection, right? It's there. The vagus nerve is that connection. That is the gut-brain connection. So here are a few more fun facts. This is actually from a researcher and psychology professor in Berkeley. His name is Dr. Keltner. You might have heard of him. So a high vagal tone results in the capacity to make decisions. It stimulates the release of oxytocin. Michelle has mentioned that. Important for birthing process, for our nursing mothers, for the whole family, for dad as well. Bonding, that's oxytocin. That's the vagus nerve. It optimizes your heart rate. It supports communication, social engagement, pro-social emotions such as compassion. We talk about compassion a lot these days. People tend to feel less depressed with a high vagal tone, and it enhances the immune system. Another big word these days is inflammation. the neurotransmitter that the vagus nerve uses lowers the inflammation rate in the body, and thus it has the ability to reduce pain. But again, it can only do so if it's unrestricted. It can only function properly if its structure is able to move well in its surrounding tissues. So this is this older model of the autonomic nervous system. And like Michelle said, they're all models. I'm going to use this one because I want to point out one thing. This is the parasympathetic realm, and this all is the vagus nerve. There are some other nerves up here and down in the parasympathetic plexus that have a role in the parasympathetic nervous system, but the vagus nerve is the main player for the parasympathetic nervous system. And let's look at the nervous system again, because I think it's really important for us to understand that the nervous system is the most connected and complex structure in our body. It has the ability to send information all throughout the body through a lot of different mechanisms. We're going to look at 4 different ones. Electrical, so the nerve impulses, the neurons are interconnected. They can send information from one end of the body to the other in milliseconds. We have the mechanical connection. This is what's very interesting for us, the continuity of the nervous system, right? We have the brain here, the spinal cord, and we go into the left pinky toe. That's the connection, or wherever you want to go with this. And then the biomechanical aspect are the neurotransmitters. Again, oxytocin that I mentioned a little bit ago is important for that one. And then electromagnetic are brain waves. So these are 4 ways how the nervous system communicates in our body. And I want to come back to something. It's so important, I'm going to mention it again. And it's the ability to cycle back. And I'm going to add a little orbit right here. This is the social nervous system that Michelle was talking about. Parasympathetic, sympathetic. What this comes down to is the ability to cycle in these 3 different nervous systems. Like Michelle said, we don't want to be stuck in one. If we're stuck in one, we can tend to be depressed. We can tend to have anxiety. It's the ability to cycle back and forth, and we're only able to cycle into the parasympathetic realm if the vagus nerve has the mobility. I wanted to bring an example that I always think about when I'm driving. I'm trying to be pretty relaxed when I'm driving. You know, I'm probably not, actually, but I hate driving. But I also need the ability to very quickly access my sympathetic nervous system. If there's a car stopped in front of me, suddenly I didn't see it, I need to be able to hit the brake quickly. And if afterwards I'm able to settle back into those more calm states, that's where the resiliency comes in. That's where the ability to cycle in these realms comes in. One other aspect that I want to clarify is also, to me, it's not about always the activation of the parasympathetic nervous system or even of the vagus nerve. It's about freeing the structure so it can do whatever it needs to do in any given moment. And if you're interested in this cycling, another great guy, I have resources at the very end of this, of your presentation. Peter Levine's somatic experiencing works a little bit more with awareness of the body, a little bit of social interaction. He's a great guy. He just released a new book in an unspoken voice that talks about that a little bit more detailed. Somatic experiencing, and it's at the very end of the slides that you have there. So let's look at the anatomy of the vagus nerve. Michelle mentioned the wanderer already. And this is a really old image of the vagus nerve. And I just love it because it shows how huge and its implications in the bodies are. So the vagus nerve is by far the longest cranial nerve in the body. It's a paired nerve. It's on both sides. It sends fibers to the viscera of the neck, the thorax, and the abdomen. And despite so much research in the field of the vagus nerve, its function is still remaining imprecise and theoretical. So we can just assume and, take our experiences and maybe put an explanation to it, but always remind yourself this might be what's going on, and it might not be. And the reason I want to go into anatomical details, again, the founder of osteopathy, Andrew Taylor Still, actually only taught anatomy and some physiology. He never taught techniques because he thought that if we know all the anatomy, we can just do whatever we know with the body. We don't need to know techniques. There are some pros and cons to it. I think when you're really new to this work, you're going to be like, okay, now I know all the anatomy, what now? You're just standing there. I don't know what to do. So we are actually going to learn some techniques today. But the more anatomical knowledge you have, the more clinical results you're going to be able to get. So one technique that we're going to look at today is vagus to lung. And what I loved, I actually got an email from someone. She's in the room. I don't know where she is. Who I taught these techniques to, and she was saying that she had such great results working with a completely different organ that I taught in the techniques, with a completely different technique. And that's what I want you to do. Take it, there's so many organs in the body, I won't be able to teach you every single organ. But take what you've learned as far as anatomy goes and apply it to wherever it's necessary in the body. So, the vagus nerve. The vagus nerve originates in the brainstem, exits the cranium through the jugular foramen, together with cranial nerve 9 and 11, glossopharyngeal and accessory. Very important, you just learned that. And then it continues down the neck, medially to the sternocleido. And we're going to be looking at this closer when we learn a technique right here. But I want to go back to the jugular foramen, just in case you forget what exactly it is. So we have the occiput in purple right here, and we have the temporal bone in red, pink. And this heart-shaped structure right here is the jugular foramen. Here's another image of it. You can see all three nerves: accessory, vagus, glossopharyngeal. Interesting aspect about the jugular foramen is that I want to get this right. The left one is a little smaller than the right one. And I can absolutely tell you that in my clinical experiences, I've seen much more restrictions, inertia in the left side of the jugular foramen, but also in general, left side of the vagus nerve. And it might have something to do with the anatomical differences. It might not. Who knows? But it's an interesting fact to know about. So we'll continue into the thoracic inlet. Here again, vagus nerve through the neck. And it continues behind the heart, posterior to the mediastinum, but it does innervate the heart. And then we'll look at this structure. So in this image, we have the heart still in, diaphragm, oops, that's too far. Diaphragm, right? Heart is still in, and in this image, the heart is taken out. So we can actually see the esophagus and the stomach. And what's interesting, what happens is that Initially, we speak of right and left vagus nerve, and then around the esophagus, it builds a plexus. You can see that right here. This is the esophagus. It builds a plexus, and then it turns into anterior and posterior vagus nerve. And it used to be thought that right one correlates with anterior and left with posterior, but because of the plexus right here, there are so many interconnections in the fibers that I wouldn't assume that that's the case if you ever work with, the anterior vagus nerve. You can't assume that it might correlate with either side of the jugular foramen. Does that make sense? Okay. Good. We have the vagus nerve right here. I just want to continue really quick. Below the diaphragm, the vagus nerve continues to innervate anterior and posterior stomach, duodenum. And you don't need to write this down. You have it all behind this slide. There are 2 slides where I've written it down for you, because this is a lot of information. It innervates the pancreas, the duodenum, the small intestine, all these loops right here, the large intestine. Remember that it doesn't innervate the descending colon. There's actually the parasympathetic nerve fibers of the sacral plexus take over at that point. So as far as colon goes, I'd say ascending colon, and to make it easy, transverse colon, but not the descending colon. Michelle mentioned earlier kidneys, but not adrenals. And there's a lot of confusing information out there about what it innervates and what it doesn't. I've actually seen, you agree, thank you. A lot of times adrenals, yes, and a lot of times adrenals, no. I've come to a conclusion about no. And one other aspect, just behind the stomach, around this level, the vagus nerve forms another nerve plexus, and that is our solar plexus. And this is something we're going to be working with later. Solar plexus is so known to us as our seat of intuition. I find it super important with the little guys to be able to work with it. It's just, it seems to be more of a center from where they're interacting and acting from. That's why I included it as a technique to work with. The vagus nerve innervates the spleen as well. I forgot to tell that. So it's not shown here. It's just behind the stomach. And then as far as function goes, this will be a little repetitive, but I think, but I think some of the things we can't say often enough. So the vagus nerve contributes to swallowing and to suction. Suck, swallow, breathe for these little guys. There might be a vagus nerve restriction there that hinders them to be able to do so. It innervates the vocal cords. Michelle was talking about this squeaky voice. Hoarse voice can be an indicator as well. And what I've seen a lot is a very throaty voice when the adults too talk very far, like it's almost like something is stuck back there. And it can also have to do with plum pit syndrome. Are you familiar with that? So it's basically, it feels like something is stuck in your throat. We've all had the experience where actually something was stuck in your throat, but people, adults tell me that they have that feeling, and that's more my clinical experience with vagus restrictions is I feel like I constantly have something stuck in my throat. And obviously the little ones, the infants can't tell us that. It innervates the acoustic meatus, tympanic membrane, also the auricle of the ear. To me, that's really interesting to look at as far as middle ear infections go. The posterior meninges, occipital headaches. If the kids are talking, they might be able to tell us something about that. Adults can definitely relate to that. Unconscious functioning, all of the innervation of the digestive tract. So motor role, peristalsis, endocrine secretions, important as far as pancreas and liver and gallbladder goes. That's all vagus related. Smooth muscles of respiration and heart tissue. And I mentioned already spleen activity, renal activity, and liver and gallbladder. And one point I want to make that, again, Michelle has touched on already, but I find it so fascinating. So the vagus nerve does so much already, right? It innervates so much in our body. So efferent information. This is only 10 to 30% of what the vagus nerve does. 70 to 90% is afferent. Information of how is our internal environment of the body doing. And I just want to send that out there too. To me, the gut is so related to the external environment too, and I think the vagus nerve has a big role in that as well, as far as how do I relate to my own body, how do I relate to the external environment, and I think the vagus nerve has a role in sending that afferent information to the brain as well. Something interesting about the vagus nerve, or about the digestive tract, is that if we experience pain in the digestive tract, we know something is not quite right. Usually those fibers just send information about, oh, this is happening, this is happening. If there's pain, something is going on. But the pain is different for the gut than it is for the rest of the body. It can be extremely vague and diffuse, and it can refer out to the somatic body. And I find that important for infants because I wouldn't just assume if a kid says its knee is hurting or its hip is hurting. This is the same for adults, but even more so for kids, that that's actually what's going on. A lot of times that can be referred pain, and there can be definitely, the origin can definitely be visceral, especially hip related. I see that very often, that people say my hip hurts, will work on some structure in the abdomen, and the hip is free again, through different mechanisms, obviously, not only this one. Good. The next slide is one I am really excited about. I'm a little nerdy. So this is, it's not a like happy baby or whatever, it's a nerve. So this is a nerve. This is like one of our vagus nerves. And we have our axon right here, right? This is the nerve fiber. And what's important to know as far as nerves goes, they consist of 50 to 90% of connective tissue. This image might not show that very well, but connective tissue is what we work with, right? That's our ability, what we can access. And what we're going to be able to access specifically is what's called the epineurium. The epineurium is the outer layer of the nerve. It's fascia, it's connective tissue. That's what we're going to be able to access. And if you remember Sarah's presentation yesterday, she was talking about the dural tube, right? So we have the dural tube. Dural tube is in the spine, but we have the dura, intracranial dura. We have the dura around the spinal tube. And yet it continues out into the epineurium. That's the same tissue. So it continues out into all these little nerves right here and into everything in our body. I want to try to go back to this one slide. This one, right? The continuity. This is the mechanical continuity in the body, the epineurium. That's what we are going to be able to work with. So I find it very often that I'll have to access the dura at the same time as accessing a nerve to be able to work with it most efficiently. So we have these 3 layers. And another interesting fact, nerves are highly vascularized and innervated. Any structure that's highly innervated can be extremely painful. The nerve. Oh, I was talking about this. This could be our vagus nerve. This whole thing, all of this together is one nerve. And it could be our vagus or ulnar nerve, whatever nerve. This is the breakdown of one nerve.
And where's the nerve within that receives innervation?
All of the fibers receive, so this is a single nerve cell right here. And the nerve anatomy is very specific and gets, it might be tricky for you to grasp it. It's very detailed. But what's most important, just remember, if you are working with the nerve, you're working with the epineurium that has continuation into the whole dural tube and intracranial dura. I think that's the point I wanted to make with this slide. So if we look at a single nerve, let's look at what it actually does in the body, what mechanical properties it has. And so let's again assume this is our vagus nerve right here, coming through the jugular foramen, through the neck. It has the ability to glide in its surrounding structures. It has the ability to shape change. And it has the ability to stretch. I can't show that very well. So it has the ability to adapt super well to the numerous demands that are placed upon it, right? Thinking, if I move my neck like this, the nerve will have to do a lot in order to be able to accommodate that. And another interesting aspect about nerves is they're made out of material, it's called viscoelastic material. And I'll explain what elastic material, tissue, is able to do. So elastic tissue, when it bends, it regains its original structure right away. Right? It comes back to neutral or whatever you want to call it. A nerve will regain, so a nerve is bent, will regain a little of its original structure. So if I bend it like that, it'll come back much more slowly and might regain a little bit of the deformed shape. And the reason for this is that even more so, the nerve is going to be able to adapt better to the numerous demands. So if it was only elastic material, it would be less adaptable. That's what it comes down to. A nerve is very adaptable, a very adaptable structure. But, and it also gives it resilience to being overstretched. The downside of that is, and we've all seen and heard about it, is that it's very, what's the word? Vulnerable to compression. We all know of our sciatic nerves, and that's what exactly the case that is going on with the vagus. It's extremely vulnerable to compression. What the body does, it always has its smart ways and reasons to do things. So it rather has a compressed nerve that's less of an evil than a ruptured nerve. So this leads us to understand the main principle in neural manipulation. Boral coined this term, neural manipulation. Come on. The whole art of neural manipulation lies in applying an effective amount of traction without an excess of compression. So we're gonna be able, or we will have to be able to hold on to the nerve, to get a hold of it as good as possible. We're gonna use a lot of levers and handles without compressing it. And we have to be so careful about that. Because any force forceful or too insistent technique can leave your client with significant and long-lasting pain. So again, we want to be really gentle when we work with nerves. We want to use minimal compression. And Michelle touched on this already. Ground yourself and embody vagal states. And I want to walk you through a little exercise where, if you want to, you can close your eyes if you're able to access your own body better that way. And maybe think of whatever grounding means for you. For me, a lot of times I like to connect to my feet, maybe have the image of roots growing out of my feet into the earth. And start focusing on slightly longer exhales. And I'm noticing an immediate shift in my own body, but also in the room. And as one of my teachers would say, maybe bring something into your attention that gives you a sense of okayness. And words such as love and trust and compassion and joy come to my mind. So as we're going to be moving into the exchange in just a short while, I'll try to remind you of these hopefully some sort of felt sense in your own body. And you can slowly open your eyes and maybe engage a little bit more in the social nervous system again. It felt good. And another aspect in the principles of nerve manipulation, and you don't have that written down on your slides, and it's actually one of the most important ones. I just added it yesterday. I'm like, it's a good one. We are going to be working with very specific structures. So it's absolutely easy to be like, ooh, what's going on here? This is exciting, which is awesome. Remember that you're working with one whole body and that it can have implications and responses. And you're going to be able to feel that if you're open to working with the whole body. So let's look at how to find out if we're going to work with this nerve or not. And my main point with this, I should have made it bigger and bold and underlined. The indication for working with the vagus nerve is your manual evaluation. So you're going to have your own ways of finding out, am I going to work with this or not? Sarah was talking about the dream body yesterday. I don't know much about it, but it sounded like that's how she finds out. Is this something that is coming up for this person? And I'm going to teach you a couple of different techniques. Some of you might be familiar with through Carol's training. And And if you're not familiar with them, I'd love to invite you to play with it. I always think that the more tools we have in our toolbox, the better. It's the same for techniques. It doesn't always mean that one very specific technique comes up very often to use, maybe once a month. But you have that tool in there for that specific client, and that's the most efficient technique to use with that specific client. And it's the same with listening techniques. And the other indications that are very small and maybe just help us gain information about this person are what we are going to hear from their intake, maybe, when they're talking during the session. So Michelle has mentioned that voice, problem swallowing, throaty, hoarse voice, the little ones vomiting, crying after meals. That can have something to do with the vagus nerve and the inability to digest well. Colic, and to me, colic is a lot of times a combination of tummy issues and the inability to regulate. Pretty much was what Michelle was talking about, regulate your nervous system. Pale, abundant sweating. I hear clients talk about, for no reasons, I'm sweating so much, especially my hands. On the psycho-emotional realm, depression, lack of will, withdrawal, melancholy, sadness. Digestive, a few other digestive aspects are actually overproduction of hydrochloric acid. Might have to do with reflux as well. Nausea. But remember, first and foremost is your manual evaluation. So these are the 4 treatment evals that we are, going to be looking at. Who is familiar with general listening? Okay. Local listening, probably the same group. And then let's look at motility first. This is the back of the room, the motility. And then mobility testing. Okay, great. So, can I have a volunteer? I want to show a few things. Yeah, come on up. Oh, now 2 people are coming up. Or yeah, I'll have you help me with the table in just a moment. Yeah, just a moment. So I just want to show how general listening looks like. Usually I would have her take off her shoes, definitely take her glasses off. It's okay for now, since I'm just showing it. So general listening, usually you stand behind the person. And if you've never done this, I would suggest closing, having them close their eyes can be a little bit easier. And you're gonna put your hands on top of their head. And honestly, this is so easy, and at the same time, the hardest thing. The easy thing, it's all there for you. The information is there, you just have to trust what you feel. What you feel, my teacher would always say, what you feel is right. It just depends if we're talking on the same level, the same language. But never doubt what you feel. It is what you feel, you can't change that, that's a fact. So I'm gonna put my hand on top of her head. And what I'm looking for is the first deflection in the body. And it's subtle. No, there's no question about it. And there was very little pressure on top of your head. And her body might do something like this. Body might be doing something like this. And it's not the strongest. It's easy to confuse. There might be a light deflection like this. And I'm exaggerating, obviously. But then there's a really big one, and that excites us. We're like, ooh, that's the one. It's not. It's the first one. Let's see. And as far as nerves go, you a good indicator to figure out, is this a nerve, is that it's gonna end in a specific area where the vagus nerve is located. That's where the anatomy comes in handy. So an easy one, for me it's always easier to find things that are closer to my hand. So an easy one would be in the neck. I might have a deflection that has a side bending in it, and an end feel, a stop. Your hand will stop in a certain area. And then something interesting comes in, and that is local listening. If I put my hand onto where my hand is stopped, is this okay for you? Specific to nerve tissue is a stringy sensation. That's the word I like to use. And I'm a very visual person. I do see colors a lot, and for nerves, I do see yellow a lot. I don't know if it's because of the anatomy books that have it be yellow. But, and another good one is that things just feel fast in this area. It's an agitated movement. It's something I get fast really, really often. Agitation, oscillation is another good one. You can have a seat, thank you. When we look at mobility of the nerves, we can test if we have access to the nerve, and that's almost only in the neck area for the vagus. The nerve shouldn't feel hard. A healthy nerve is not hard. It's not sensitive, other than when we hit it, our funny bone, right, the ulnar nerve. If we hit that, it's sensitive, but on just local contact, it's not sensitive. And freedom of movement. If we have the ability to test the nerve with actual mobility testing, and again, that's almost only possible in this area, it should be able to move, right? Becker had a great book, Life in Motion. And then the motility, and if you're not familiar with motility, it might be tricky to access, but again, trust what you feel. The motility is the inherent movement, very subtle, inherent movement of anything in the body. You can feel this in a bone. You can feel this. This is the life force to me. You can feel this in an organ, and you can feel it in a nerve. And so for the nerve, a healthy motility movement for the vagus nerve right here is superior and inferior. If we look at distal nerves, we have, an peripheral movement and a central movement. And for nerve plexi, and we're going to be working with the solar plexus, the celiac plexus, it's a rotational movement. And this is an exaggeration. You're not going to be feeling this. Clockwise and counterclockwise. And about the same amount. So if you have very little counterclockwise but very big clockwise movement, that might be an indicator that something is not quite right. All right. So now we know how to find out if the vagus nerve is restricted. After we've found out, oh yeah, let's see, there's something going on with the vagus nerve. There are 4 different techniques I'm going to be introducing, and 3 of them we will use today. The one most people will be familiar with is unwinding. And I have a great announcement. Nerves really like unwinding. It comes to us so easily, and nerves like it. It's a good one. But again, let's have as big of a toolbox as we can to be able to address each and every client that comes into it. There might be the client that needs a direct technique, and none of the techniques is better or not so good. It just depends on what the client needs. So a direct technique is that you actively, I have to switch here, oh no, challenge the restriction. So if you notice the restriction is in the middle of my 2 fingers here, you'll actively challenge the restriction. An indirect technique is the opposite. You will increase the pattern of restriction. And just to clarify, unwinding can be indirect movement. It can even be direct movement, but it changes a lot more. It'll go back and forth, and you just follow what the tissue wants to do. The only time when you interfere with unwinding is when you notice a pattern emerge. So it goes in a circle and nothing else is happening, or it goes in a figure 8. You might want to give it a little nudge and be like, let's explore what's beyond this figure 8. So direct technique is what I like to call away from the fixation. Indirect technique is go into the direction of ease, the direction that's easy for the tissue. And then flossing is literally what it sounds like. You're going to be able to have a handle on the nerve, and you're going to glide it. Remember the epineurium? You're going to have a handle on that. You're going to glide it within the rest of the connective tissue that's surrounded. And there might be some stuckness, some restriction, some inertia right here, and with the flossing, you're going to be able to guide the nerve out of that restriction. And unfortunately, we won't be able to get into much when to use which technique. I'd say trust your intuition. There are some very specific ways to figure out which technique is the best for a certain client. Okay, so I'm curious what you see in this picture. What's the first thing that comes to you? It's called, called the slide "Children Are Not Miniature Adults." What do you see? I don't hear anything.
Short neck.
Oh yeah, it does have a short neck. Yeah, I heard it. The thing that came to me first when I saw this picture is the liver. Oops, and this is a normal liver. So the baby's liver is twice the size, proportionally, to an adult liver. So relatively twice as big as an adult liver. And we have to be able to know that when we work with it. You know, the liver will be all the way over to the left side of the rib cage. We have the thymus gland right here, right? That's important to know that it's still very big for babies. Look at the diaphragm. I'm curious what you notice as far as the diaphragm goes. Yeah, exactly. It's very high, flat, straight. So it's a lot more horizontal. And that also is perfectly normal for a baby. That's just their anatomy. So the ribs will move differently. They won't move up and out. They just move up. And the diaphragm pushes the liver a lot lower as well. So the liver is pretty low. And adrenals are enormous. They're almost the size of the kidneys when a baby is born. Let's see if we have anything else. I think that's pretty much it. Good, just good things to remember when working hands-on with babies. Okay, so here are the 3 techniques we'll be working with today. And Carol, will I have a little extra time since we started late? Only fair.
How about 10 minutes?
Okay. 3 techniques we'll be working with, and I think what I'll do is I'll have a demo for this one, and I'll walk you through this. I think this one will come really easy to you, and it will be unwinding. So let's get everything off the tables. I'm gonna get the air mattresses, and if at all possible, make room so you can sit at the end of a table, which might not be possible. So the next technique we'll be looking at is vagus to lung. And this one you can apply to anywhere in the body. If you want to play with it today already, if you notice, oh, the lung doesn't really need treatment, vagus to lung doesn't really need treatment, it's vagus to small intestine, play with it if you feel comfortable with it. And we're going to work with the different lung lobes. And this is the outline. Here's our male body. I couldn't find a better picture. So the left lung, so we have, I always remember it by thinking of the heart being slightly to the left. So the left lung only has 2 lobes. There's not more room for 3. And the right lung has 3 lobes. And the inferior one on the left side is really low. So when we're going to test that, you have to be pretty low. And then we're going to be testing right lower lung lobe, right medial lung lobe, and right superior lung lobe. And as far as our little guys go, this technique I've actually used quite often with babies with shoulder dystocia. And the reason for that, during the birth process, the reason for that is, and I actually talked with Sunshine for a moment earlier, she's a midwife, and I was asking her some question about it, because what I've experienced is that what I feel in the lung tissue itself is that there's lack of expansion. And this is what happens with babies with shoulder dystocia. The head is born, they're trying to take their first breath, but there's no room for it. The rest of their bodies is still in the womb, in the mom's body. So I found that a lot, and we can work with the lungs directly for that, or we can do this technique vagus to lung. So you're gonna take a handle. Let me actually see something really quick. Yeah, so we'll start with our general listening again. This is, to me, the easiest way to find out what's going on. And this time we'll have, again, the first deflection. We might notice the shape of the vagus nerve in our deflection. So we know where it runs anatomically. We might feel that it follows that path with either a stop in one of the lung lobes, so inferior, superior on the left side, inferior, medial, superior on the right side. And what we can do, so this is the general listening, what we can do is, I'm going to lie on your back, please. We can do a spring test for the lungs. And granted, we always have to remember this could be a rib restriction too, or a purely pleural restriction. But in our general listening, we got the shape of the vagus nerve, and that's what told us, oh, the vagus nerve is involved in all of this. And this is more mobility testing, so you're actually gonna get into the very inferior lobe, and you're just gonna test how well is it coming back, and you're gonna compare it with all the other lobes. I'm going to stay on this side, but I would do it from this side. Inferior lobe. With women, the medial lobe is a little tricky. I'm just going to make some room here. And you can do this very gently with babies. They don't, they don't mind it at all. That's the spring test in the lungs. And this is, again, our pre and post test to see. She asked, what am I feeling for? 2 things. I'm going to feel, am I able to get into the tissue easily? And how well is it coming back? That's why it's called spring test. If there is some slowness, it comes back to me to lack of mobility, lack of movement in the tissues. That tells us a lot. And again, this could be definitely rib related, no question. So we do general listening, mobility test, spring test of the lungs. And then, who's familiar with the jugular foramen and has worked with it, around it? Okay. So again, the jugular foramen, temporal bone, and occiput. Let's see. So I'm going to go behind the mastoid process. This is the temporal bone, the mastoid process. Behind it will be the occiput, posterior to it. And you're going to be able to have a V handle on it. And you're going to be able to follow in the direction of effort this time. So let's say I'm going to be working. So I would probably do it, if I worked with her right side, I'd do it right side, hand here, this V hold, one hand on the temporal bone, on the mastoid process, and one hand clearly behind it so that you're on the occiput. And then you have the jugular foramen in the middle. And let's work with her superior right lobe. And for her, the direction of effort. Actually, I'm noticing I just want to move my superior hand, and I'm going to have a maybe a baseline or a this hand stays pretty still actually for her. It could be that both hands move in the direction of effort. Remember, away from the fixation, disengaging the fixation.
Are you loading into your hand on the lung?
Yeah, good question. I am loading into the hand of my lung. So this one is not just resting there. There is a bit of a load. And you just follow, you do follow the tissue. It's not only you. You're inviting the tissue to go into the direction of effort. And if that's the indicated technique, then the body will like it. It'll be yummy. And once you get the idea around release, sometimes it's really easy to feel, right? This sense of settling, a sense of peace, a sense of your fingers aren't, your hands aren't moving quite as much anymore. That's a good sense that there is a release happened. You can feel it in the room sometimes in your own body. I feel it in my own body a lot, where I take a deep breath, the clients might take a deep breath, and I notice how the tissues are shifting into a more balanced, a more mobile state. There's just more health vibrating from the tissues. And I know we all have our different languages for it, but I think a sense of peace is really a good indicator for a release that happened. And then I would do again the spring test. For her, I'll do it on this specific lung lobe, because that's where I worked with. Is there a change from pre-treatment to post-treatment? And then I would do the general listening afterwards. Again, I always do general listening at the end of my sessions to see what have we done, what changed in the body. There are a lot of questions. I saw the one in the back first, and I'll repeat, Carol. Yeah. Okay, she's asking, am I working the length? So the movement she did was this. This reminds me more of flossing. And then the second movement she did was more of a disengagement. And that's what I would say is the technique we're doing. So it can either be a disengagement for both hands. For her specifically, I noticed that it seemed better to have just this hand was still and this hand was moving. And this is a huge exaggeration, obviously. You noticed how subtle the technique was. Mm-hmm. Does that make sense?
So is there a little bit of an unlocking as you follow?
It can happen. It can happen. The techniques can overlap. Mm-hmm.
When you do these techniques, do you ever, at any time, during doing them, a still point?
Yeah. I mean, Still points for me, I don't induce still points, but they absolutely come up. Absolutely, yeah. And a lot of times that's what I was saying, that sense of peace that can be a still point, and the body recalibrating, reorganizing. Okay, I'll have you, yeah.
Are you modifying your general listening for infants, or are you not doing and just doing local?
Am I modifying my general listening for infants, or am I just doing local listening? I do it. I do it. I might have them lay down if they're on mommy's arm. You can do it anywhere, anyhow. Yeah, with the toddlers. You can even do it from the feet. I do it from the feet a lot, actually. Yeah, you can do it while walking. You might want to, yeah, it's trickier, and if you have a toddler, there's movement in the body. It's different, it's harder, for sure. I love how Carol always says it's so much easier to work with children. In some sense, it totally is. But then you have a toddler in your room, and you're like, how am I ever going to work on you? They're just running like crazy. I think Melissa had a question.
Right now, articulate questions. We were talking about if there was maybe like a shoulder dystocia or brachial plexus issue, and how it impacts respiration. How clear is it to you when you're working with it that it's a vagal nerve and not like a phrenic nerve issue, or does it matter? Is it clear in your hands, or does it?
It would be, yeah. And then you would have to get into more. Oh, yeah, sorry, thanks. She's asking how clear it is if it's, for example, a vagus nerve issue versus a phrenic nerve issue. Now, the phrenic nerve innervates the diaphragm, and obviously it's all very close together. And then we would have to look at a lot more detailed at the phrenic nerve anatomy. And I'm a very visual person. I get when I do general listening, I get a picture, the pull that I'm feeling. I'm going back to my anatomy, and I feel that certain pull. And the phrenic nerve has a different pull. And, just as far as the origin of the phrenic nerve goes, it's quite different. You would be able to distinguish it. Baral has a book on peripheral nerves where the phrenic nerve, I think, is in. Actually, don't have that book, but yeah. There was one more question, and then we will move into exchange. Yeah, go ahead.
You were on your upper lobe. If it was a middle or lower lobe, then you would have your hand.
Yeah, absolutely. She's asking if I would switch the position if we are drawn to the inferior lobe, for example. I would have my hand on the inferior lobe, but still on the jugular foramen.
And then you have this movement. Do you ever do this movement?
So she's asking, I did this movement. Would I ever do this movement? This looks to me more like an indirect technique, and they can totally follow each other. They can go from one to the other. In the end, the goal is the release, maybe the still point, maybe that sense of ease. Whatever the body offers, whatever the body wants. There are very specific techniques to find out what technique to use, but I'd also trust what you're feeling. In the end, I think that's what it comes down to, really trusting what the experience is between you and the client on the table. Okay, let's get to the tables. So the next technique will be your homework. It's the solar plexus technique, and the solar plexus has fibers from both the parasympathetic and the sympathetic nervous system. The way to find out to work with the solar plexus is by, guess? Asking the body, yep. I would do general listening again. It's my go-to. I do it with every client. So the general listening for the solar plexus would most likely be a posterior pull. I'm exaggerating, right? Posterior pull. You wouldn't notice, you wouldn't see this at all. I'd have my hand on someone and you wouldn't see anything. But what I'd feel is a posterior pull with a pretty abrupt stop just below the diaphragm. And that's where the solar plexus is. It's just in front of the spine. So many times we think of it as being quite anterior, but it's actually just in front of the spine. And if you put your hands on it, so I'll have a posterior and anterior hand. The posterior one will be closer to the plexus itself. And I would say I'm on the lower thoracics, upper lumbars. I'll have an anterior hand. And with the anterior hand, I'll have to think my way through the layers. So I have ribs, I have muscles, I have fascia, I have the stomach, the pancreas. There's aorta. There's lots of things in the way. The plexus is quite far posterior. And there's a motility to this plexus, right? I mentioned that earlier. Very gentle, an absolute exaggeration here. Clockwise and counterclockwise movement. And even checking in with it and noticing I want to rush it, I need to take my time in order to feel what's happening here. And the technique will probably be really familiar to most of you. You're just going to follow your listening. You're just going to follow what you feel. And that might go very three-dimensionally, right? It can go in any direction. Again, you're only going to interfere if there is a stuck pattern. If it always does this, I'm going to say, hey, let's explore. Nudge it very gently into another direction. And again, this is a fabulous technique for balancing the parasympathetic and sympathetic nervous system. But you're not going to have the idea, oh, this person needs more balance. The way to find out is by your manual evaluation. And you can play with this at home. And what I would suggest is that, is it okay if I stay on your body while I'm talking? Mm-hmm. What I would like to suggest is that if people have questions, we're just going to gather up front here. People want to move into lunch because we're definitely running late. You can move into lunch and maybe see the Q&As on the video, or if you don't have any questions, you just need food, I totally understand. And I think we'll be able to record it as well. Okay. One second. If you have any other questions, feel free to shoot me an email. I'm going to disengage here. Where's my little clicker guy? I think you guys should have, oh look, yeah, at the end, we all have happy babies, right? Thank you, guys. There's my email address at the end of your presentation if you have any questions. Thank you.